So next is acute and chronic liver transplantation. Or living donor liver transplantation. It's V2. A 50-year-old male with a known history of the chronic hepatitis B carried for over 2 decades, present through emergency department with acute onset of symptom. He was severely jaundiced with confusion and fever. He had defaulted on his regular follow-up for many years. Clinical exam in ED demonstrated stigmata of chronic liver disease, and abdominal exam was positive, shifting dullness. What are your most likely differential diagnoses in this scenario? Acute and chronic liver decompensation triggered by common infection like UTI, respiratory tract infection, SPP, hepatitis B flare-up, HCC, and acute portal vein thrombosis, alcohol, drug-induced. Other surgical causes of obstructive jaundice are cholangitis and cancer. What would you do next? I would take a concise and targeted history and physical exam. Especially, I would like to know the localizing signs for infection, social history of alcohol and medications. An examination, I would look for jaundice, ascites, pain, peritonism, fever, signs of sepsis, mass, liver mass, splenomegaly. What investigation you will do? So I will do full blood count, hemoglobin, white cell count, platelet count, and PT, INR, liver function test including bilirubin and albumin for child post status, and then ALT, AST to see acute hepatitis picture, renal panel, septic work of blood cultures, urine culture, chest X-ray, hepatitis B virus DNA, viral load, and then I will do metabolic screen, acute viral hepatitis, autoimmune hepatitis, and I will do CT scan or ultrasound, look for HCC or portal vein thrombosis. Test results compatible with acute and chronic liver disease from hepatitis B flare and started on antiviral treatment. Scans show solitary 6 cm HCC in the right lobe. Managing surgeons and hepatologists decide that an urgent liver transplant is his best chance of survival and to list for deceased liver donor transplant. What are the criteria which determine the priority of listing in Singapore? So 1. Status. 2. ABO blood group compatible based on MELD score or waiting time. Status is equal to 1 or highest priority can cross the blood groups. What is the MELD score? MELD score is a model of end-stage liver disease score. It is ranging from 6 to 40, calculated based on the lab tests like serum creatinine, INR, bilirubin. It's a reflection of severity of the liver disease. The higher the score, the greater the severity. It predicts disease-related mortality at 3 months. Does the patient meet criteria for deceased donor liver transplant listing in Singapore? Yes. What are the criteria adopted for HCC listing in Singapore? So it's University of California, San Francisco criteria that solitary tumor less than 6.5 centimeter or less than 3 fewer nodules with the largest tumor more 4.5 centimeter and total tumor diameter less than 8 centimeter. No vascular or extrahepatic invasion. Discuss and compare with the Milan criteria. Why is there a criteria for HCC listing for liver transplant? This is purely due to organ scarcity. The hepatocellular carcinoma is to ensure liver transplant for HCC results in post-transplant survival that is 7 to 80% for 5-year overall survival compared with the liver transplant for benign disease. The patient is deemed to be fit for liver transplant after completing workup and listed on the deceased donor transplant list with a MELD score of 30. The patient has strong family support who visit him daily. Family members are very concerned when they are informed that he is unlikely to recover for a liver transplant, and due to the shortage of the deceased donor organs in Singapore, there is a high possibility he may not receive an organ in time, even though he is at the top of the waiting list. What would you offer them? Consider living donor liver transplant. The patient's family members include a wife, age 45 years, 2 adult female children, age 22, 25, and 1 male sibling, age 40 years old. What would you do next, and how do you work up the donors? Key principles of living donor are the willing donor, no financial, social, emotional, psychological inducement or pressure. Donor safety takes priority over recipient survival. No medical issues, liver issues which put donor at any increased risk. full informed consent, including risks to donor and prognosis of the recipient with and without a transplant. After offering and discussing options for live living donor liver transplant, wait for potential donors to voluntarily set up. All four members set up and potential donors. It is important to interview all potential donors individually to ensure they meet the willing donor criteria. If anyone has issues who socially or emotionally can't explain openly, then we medical board will make him medical reason deem unfit for live donor transplantation. Thank you.